Good morning. I'm Dr. Stuthi Ravi, Junior Resident, Department of Radiodiagnosis, Kasturba Medical College, Manipal. Today I'm presenting a paper on ultrasound-guided ablation of thyroid lesions under the guidance of Dr. Prakashni, Dr. Rajgopal, and Dr. Harshit. The aims are to demonstrate a minimally invasive ultrasound-guided therapy used to manage benign thyroid lesions and to highlight the steps of percutaneous ethanol injections and microwave ablations. So thyroid nodules are very common in clinical practice and most are benign, asymptomatic and managed only by observation and follow-up. However, some of them increase in size over time and may induce pressure and cosmetic issues. So surgical excision has been established as a treatment of choice for symptomatic benign thyroid nodules. However, it carries risk of complications, neck scarring and may result in hypothyroidism. Therefore, image-guided non-surgical procedures such as ethanol ablation and thermal ablation have been proposed as an alternative and less invasive approach for management of benign symptomatic thyroid nodules. So ethanol ablation is used widely as a non-surgical treatment, specifically for cystic or predominantly cystic benign thyroid nodules. It acts via two effects: coagulative necrosis of tissue due to protein denaturation in cysts, or ischemic necrosis due to thrombus and inhibition of enzymes causing fibrosis and atrophy of the nodule for the solid part. We performed 4 cases of ethanol ablation. So ethanol of high purity is required, approximately 95 to 99%. Pre-procedural ultrasound is done to calculate the volume of the lesion. We require a 16 to 23 gauge needle, a 10 to 20 ml syringe, and the high purity ethanol. Two different techniques are described. The first one, the ethanol retention technique, which refers to retention of the injected ethanol inside the cystic cavity of the nodule. This is technically simple, and a continuous coagulative necrosis may be seen, which causes a delayed effect and reduction in size. Second one is ethanol aspiration technique, in which the injected ethanol is completely re-aspirated after a short time. This prevents complications like pain and perithyroidal fibrosis due to leakage of ethanol. So patient is positioned in supine with neck and mild extension after skin sterilization and local anesthetic. The needle is inserted into the cystic area under ultrasound guidance. A trans-isthmic route is preferred as it leads to less spillage of ethanol. The internal fluid is aspirated. Now the debris can be cleared by saline irrigation. Then ethanol is injected. The amount of ethanol injected is based on the amount of fluid that is aspirated. Approximately 50% of the aspirated volume is injected, and the total amount of ethanol should not exceed 10 ml. This ethanol can either be re-aspirated after a short amount of time or can be left within the cyst. Case 1. 25-year-old female came with complaints of swelling over the neck. USG showed a cyst with eccentric solid component in the isthmus. So as we can see in these images, under ultrasound guidance, a needle is placed within the cystic area and USG guided aspiration of the cyst is done. After which, USG guided ethanol injection is done into the cystic area. In this case, the ethanol was not re-aspirated. So this is the ethanol retention technique. Immediate post-procedurally, we can see reduction in size of the nodule with hyper areas of alcohol within the cyst. Case 2 is a 40-year-old female with swelling in front of her neck. She was euthyroid. USG neck showed a cystic lesion in the right lobe of thyroid. Similarly, under ultrasound guidance, needle was placed into the cystic component and 25 cc of fluid was aspirated. Then approximately 15 cc of absolute alcohol was injected and retained for 20 minutes. Then this alcohol was re-aspirated, and post-procedurally, we see complete collapse of the cyst. This is the alcohol re-aspiration technique. In this case, minimal seepage into the muscular plane is also noted. So microwave ablation is a newer modality, and it uses dielectric hysteresis to produce heat. Microwave can easily propagate through the tissue with low conductivity and readily penetrate charred tissue. This leads to higher temperature faster and larger and more predictable tumor volumes. It also has a simplified setup with no grounding pad burns. It's also resistant to the heat sink effect seen in other thermal ablations like RFA, which produces a larger ablation zone. So 2 patients with predominantly solid thyroid nodules underwent microwave ablation. The technique: first, pre-procedural evaluation is done using ultrasound to characterize the nodule and evaluate the surrounding anatomical structures. 3 nodule diameters and volume is calculated. USG-guided FNAC or core needle biopsy is done prior to the procedure to confirm benign nature of the nodule, and lab parameters such as CBC and coagulation profile can be done. Devices required are the radio frequency generator, the microwave antenna, and the flexible cable. So here we see the generator with the microwave port, the display showing the wattage, the time, and the tumor edge temperature. Here we can see the antenna, which has an internal cooling system. The antenna is connected via the coaxial cable and tubing to the microwave port and the generator. Here we see the flexible coaxial cable and the tubing for the cooling. The power and time for ablation is dependent on the device and the manufacturer is based on the size of the lesion, is usually given in a chart. Case of a 26-year-old female with midnight swelling showed increase in size over 3 years, now complaining of difficulty of swallowing. USG next showed a well-defined hyperechoic nodule in the right lobe of the thyroid with small area of cystic degeneration, TIRADS 2. USG guided FNAC was done, which showed a hypoplastic colloid nodule benign. So patient was placed in supine position with mild neck extension after skin sterilization and local anesthetic. Saline and lignocaine was infiltrated around the thyroid to prevent injury to the surrounding structures, which is called hydrodissection. Secure positioning of the electrode is done through sufficient thyroid parenchyma. The entire length of the electrode is visualized. Here we can see USG guided placement of the antenna within the thyroid lesion. This is what we look for, which is the hyperechoic boiling effect, which is the boiling of the water molecules within the thyroid. So during microwave ablation, a power output of 30 to 40 watts was used, and variations of these echoes from the nodule were monitored during real-time ultrasound. This is called a hyperechoic boiling effect, which depicts the area that is ablated. The therapy is not stopped, and this hyperechoic boiling effect covers the whole nodule. So on 3-month follow-up, we can see a reduction in size with increase in echogenicity of the nodule in the patient. The other case is a 29-year-old female with complaints of non-tender neck swelling gradually increasing in size. USG showed a bulky right lobe of thyroid with a solitary hypoechoic nodule with few internal cystic areas, TIRADS 3. USG guided FNAC was done with demonstrated a benign follicular nodular disease, and patient was planned for microwave ablation. Similarly, this is the microwave generator, the antenna, and the tubant for cooling. So post-procedural imaging for the patient showed multiple hyperechoic foci within the nodule, which shows the ablated area which occurs due to the microwave. Complications of thyroid ethanol ablation includes pain, hematomas, extrathyroid leakage of ethanol resulting in voice change or reactive fibrosis in the extrathyroid tissue. Rarely, skin necrosis and venous thrombosis can occur. In microwave ablation, we can see pain, hematomas, skin burns at the electropuncture site, and voice change likely due to injury to the recurrent laryngeal. So all 4 patients who underwent ethanol injection, which had immediate reduction of cyst size and no post-procedural complications. The procedure was done on an outpatient basis, and patient had no need for admission or monitoring. 2 of the patients complained of post-procedural burning sensation and pain, which subsided within a few hours. 3 of them on follow-up showed interval decrease in size, and 1 had a recurrence of cyst, which required a further session of ethanol injection. In microwave ablations, both cases showed reduction in size and increase in echogenicity of the nodule. So image-guided non-surgical procedures such as ethanol ablation and microwave ablation provide several advantages, which is minimally invasive, done under local anesthesia, good cosmetic outcome, short hospital stay, and lesser complication rate. Ethanol injections can be used for predominantly cystic lesions and have shown excellent outcome with mean volume reduction of 65 to 96%. However, depending on the size of the lesion, multiple sessions may be required, and this may increase the complication rate. Thermal ablation using microwave shows a volume reduction of 65% in 6 months follow-up in a study by Van et al. And has less complications. These are my references. Thank you.